So we're going to be doing Coxsackie, viruses of the blood. Well, the drugs are going to be calcium channel blockers, and then we're going to be talking about some murmurs as well. Just give me 1 second to find something. Okay. Alright, so really quickly we're going to go over the RNA viruses just to brush up on this. So maybe you remember some of the categories that we've got for types of RNA viruses?
The coronavirus, flavivirus,
Hepadnavirus.
Okay, yeah.
adenovirus,
Togovirus. Togo, yeah. What's that first one that causes rotavirus infection?
Riovirus?
Rio,
Rio. What the? There we go. Riovirus. You guys said coronavirus, which is who we'll be talking about with Coxsackie. You guys said hepavirus. I heard flava. Oh, okay. So nobody said Coxsackie virus. So Coxsackie virus is known for norovirus. What's norovirus known for, which is actually in the news recently?
this is the ship cruise.
Right. And there are a bunch of Caribbean cruise lines that had a shit ton of sick people in the last few, this past weekend, I think, actually. You guys said flavivirus, which is yellow fever, dengue fever, West Nile, Zika, all those. Did you guys?
Toga?
Yeah, you said toga.
Yeah.
That's a Bella chikungunya. And then,
Retro?
yeah, retro. And then, do I have... I guess my thing is blocking the very bottom, but whatever. So I also had coronavirus there, which is, a common cold kind of virus. So we're talking about Coxsackie, and what can you guys tell me about Coxsackie?
So there's A and B.
Right. So, in your P's rotation, you're actually going to see a shit ton of Coxsackie because it presents as what in children?
Hand, foot, and mouth.
Right, hand, foot, and mouth disease. And it is pretty damn obvious when you see it. I mean, literally just sores in those 3 areas. Sometimes in the genital as well. But you want to treat it because what is the sequelae to hand, foot, and mouth disease?
Carditis? Myocarditis?
Yeah, so that's technically Coxsackie B, the myocarditis, but it is associated, so you can get. So that's the fear. That's the Bornholm disease or devil's grip. And I believe this is the most common cause of viral cardiac pathology in children, if I'm not mistaken, from what I remember from Pete's. So you will see Coxsackie a bunch when doing that rotation. And how is it spread?
By, touching?
Oral.
Fecal oral.
Oh, right. Okay.
Which makes sense because kids are gross. Okay, so I guess that's all I have for Coxsackie virus. Does anybody have any questions? And there's really no treatment for it. It's symptomatic and just stressing good hand washing techniques. But again, kids are gross, so you're not going to see that too often. All right. So now we're going to talk about heart murmurs, and we'll go over, where these sounds come from. So we classify them into systolic, diastolic, and continuous heart murmurs. So can anybody remember what are the systolic? Or actually, before we go there, let's just go over what are S1 and S2 heart sound again. What happens to create the S1 heart sound?
Mitral valve.
Mitral and tricuspid.
Right, and then the other two open. So which are the two that cause the F2 heart sound?
Aortic and pulmonary.
Right. So, what are some systolic heart murmurs?
Aortic stenosis.
Right. Aortic stenosis is one.
Pulmonic stenosis.
Mitral regurg.
Mitral regurg, yes.
Mitral valve prolapse.
Yes.
VSD.
And
VSD.
yes.
Right. So we'll go over them individually in a minute. But what about the diastolic heart murmurs?
Aortic regurg.
Mitral stenosis.
And then what about a continuous murmur?
PDA.
PDA.
Okay. So first we're going to talk about aortic stenosis, and we know that this has the classic crescendo-decrescendo ejection murmur, and an ejection click may be present. So these patients present with syncope, angina, dyspnea, and age-related calcifications in older patients and younger patients, calcification from bicuspid aortic valves, maybe something like Turner syndrome. But why is it a systolic murmur? And what is this ejection click? Well, here we have the aorta and its valves. So if we've got aortic stenosis, these valves are getting really thick and hardened and calcified, and they are not as easily to open. So as the pressure in our left ventricle increases more and more, I guess I should pick a different color, but whatever, as there's more and more pressure inside of this ventricle that is needed in order to open up this these valves, they will literally snap open once they've achieved a greater pressure. You have to open up your thing, and it'll create that ejection click. So that comes, and it's a systolic murmur because it's happening while this chamber is compressing. And so you're going to have the crescendo decrescendo, because as the pressure rises and these things flip open, then there will be an initial swoosh, which is the crescendo, as it enters into the aorta, and then as the pressure kind of equalizes, you'll get the decrescendo murmur. So that's where that comes from. Now, mitral and tricuspid regurg. Now again, I'd like to stress that whenever you see the word regurg, they tend to depict this sound as a blowing murmur. That's because we've got things coming back. So, excuse me. So during systole, we've got these two chambers, the ventricles, contracting. But if we have, as we can see in this photo, we have either the tricuspid or the mitral valves still left open, then during systole, even though blood is supposed to be going through here and through here, we're going to have a little bit of backflow or regurg, and it's going to happen throughout the duration of systole. That's because the entire time that these guys are contracting, there's some blood that's leaking back into the atrium. So again, it's going to have that blowing murmur. So the mitral regurg is going to be loudest at the apex, radiating towards the axilla. That makes makes sense. The apex of the heart is over here, and the axilla, or your armpit, is going to be here. So it's going to be radiating into your hairy armpit. Ischemic heart disease, post-MI, labs, and tricuspid, tricuspid area, which is the border, and because so now mitral valve prolapse. So this is a mid-systolic murmur with a click. So what are some things that can cause mitral prolapse? Or some patients associated with MVP?
Marfan.
Marfan's is one, classic. Ehlers-Danlos. And there's one more. Oh, rheumatic fever.
Endocarditis?
Looks like endocarditis is more of mitral and tricuspid regurg than prolapse. But rheumatic fever can be one of these two as well, because it's always typically going to be affecting the mitral valve. So this mid-systolic click comes from the fact that whether it's excessive tissue or the valves have actually kind of prolapsed or fallen down into the ventricle, as systole is occurring and the pressures are rising in the ventricle, then literally these excessive tissue valves will flop back up and they'll make a click sound as the chordae tendineae tighten up. And I know I've always remembered it kind of like a parachute opening up, that the chordae tendineae will stop the parachute from, fully retrograding into the atrium, but it does make a little sound. And it'll be mid-systole because it will take it'll take a certain amount of time for the pressure to be high enough to cause that valves to prolapse back into the atrium. And frequent valvular lesion, best hurt. That is just before it's too. Okay. Oh, and actually, never mind, Yash, I'm wrong. This one can also predispose infective endocarditis. So rheumatic fever and infective carditis are the two that are going to affect the mitral valve. And then VSD, simply enough, we're going to have some sort of anomaly, typically congenital, where the membranous portion of the VSD is absent, and this is allowing blood to shunt. Typically, it will begin from a left to right shunt because the pressure in the left ventricle is much greater than the right ventricle. Now, what can happen after a while, after you have blood going from left to right, and eventually right ventricle will get hypertrophy, and the pressure will eventually Eisenmenger syndrome. The pressure will eventually become greater in here than the left ventricle, and the shunt will be reversed. And yes, that's called Eisenmenger syndrome. Okay, so VSD again is going to be a pansystolic murmur, or holosystolic, however you want to say. And it's because the entire time that this ventricle there's blood is shunted over. And now, tell me this: what is worse? Is it a left to right shunt or a right to left shunt?
Right to left.
Why?
Because you have deoxygenated blood mixing with oxygenated blood.
Right. Right to left shunts are cyanotic, meaning a left to right shunt, the patient could be completely asymptomatic. But if you get Eisenmenger syndrome and the shunt is reversed, then the patient can end up cyanotic because there is blue deoxygenated crappy blood mixing in with the stuff that's about to go out to the system. So, yes, that is correct. So now, moving on to the, do we have any questions on systolic murmurs?
Which bedside maneuver would increase the intensity of mitral regurg? Or
Left lateral decubitus position?
that's the hand grip. Hand grip would increase the intensity of a mitral regurg.
Oh, you're going. Okay, yeah.
And then which one would increase the intensity of aortic stenosis?
Standing up?
Rapid squatting.
Squatting.
That would also increase the mitral regurg and VSD murmurs. So the intensity would increase in those. Well, both of, okay, so they both do the same. Yeah, well, with those hand grip, it's just mitral regurg, aortic regurg, and VSD murmurs. But with rapid squatting, it's aortic stenosis, mitral regurg, and VSD murmurs. All right, because with hand grip, you're increasing afterload, and then squatting, you're increasing preload. Preload and afterload and venous return. Everything increases. Okay. So, go over again which one. Okay, so if you have increased afterload. Increased afterload would be... You're making it more difficult for blood to come out this way. So you're going to increase aortic stenosis? No, you're going to increase the intensity of mitral regurg. Mitral regurg, yeah, because you're going to have more blood going this way. Aortic regurg would also increase, and VSD would also increase in intensity. Okay, yeah, VSD. But it would decrease aortic stenosis intensity.
Because the blood wants to go the other way
The blood
for
wants
less pressure.
Okay. And then if you rapid squatting, you're increasing that pressure because your venous return is high, preload is high, but you're also increasing afterload. So you would increase the intensity of aortic stenosis, mitral regurg, and VSD murmurs. Okay. But you would decrease hypertrophic cardiomyopathy murmurs, which... Right. Well, that's because in that one you've got your myocardial wall partially blocking your aortic valve. So if you increase the pressure, increase preload, I mean, then you can actually move that wall over and the blood can actually get out. So Okay. Good. Very good. Okay. And one more thing. Valsalva would decrease the intensity of most murmurs, including aortic stenosis. Because Valsalva is decreasing preload. Correct. Okay. All right, so aortic regurg. So again, it's a regurg, so we got a blowing, early diastolic decrescendo murmur. So this one you can see clinically as head bobbing if it's very severe, and a wide pulse pressure. You guys remember what pulse pressures are? Difference between your diastolic and systolic blood pressure? Right. So this can be due to dilated aortic root, bicuspid valves, endocarditis, rheumatic fever, and then it progresses to heart failure. So this is literally your valve has gotten bigger to the point where the leaflets don't quite touch anymore. So during diastole, when you keep contracting, your aortic leaflets are not fully together, so there's going to be some regurg. And this is a diastole, it's going to be pan-diastolic, and decrescendo. So then mitral stenosis follows an opening snap. And it's in diastole. So just like we were talking about aortic stenosis and mitral stenosis, we've got these hardened, calcified leaflets that there needs to be a certain amount of increased pressure here in the atria. And as that pressure rises, it'll eventually flip open these leaflets, which will cause that snapping sound. And oh, that's right. Yeah, so again, rheumatic fever can cause this one, and then chronic MS can result in this. And, that's right. So, because of the increased pressure, this aorta, you will get aortic dilation. I'm sorry, left atrial dilation is what I meant to say. What clinical manifestation can occur with atrial dilation, specifically left atrial dilation?
Orthopnea?
Yeah, because you will eventually get left heart failure.
Hoarseness.
Think more anatomically.
Hoarseness?
What was that?
Hoarseness, yeah, what she said. Like
Hoarseness? Yeah.
it's gonna impinge on that nerve, so the
left recurrent laryngeal nerve.
Laryngeal nerve,
Nerve, yeah.
Maybe dysphagia.
Boom, dysphagia, because it can compress your esophagus. And hoarseness because of the left recurrent laryngeal nerve involvement. Very good. Delayed rumbling, mid to late diastolic murmur, blah, 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 blah. Okay. And then patent ductus arteriosus. We already know. Kind of can't draw that here, but that's the machine-like murmur because of the duct still being open. And, okay, so pharmacology, if we want to close it.
Indomethacin.
Endomethacin.
And if we want to keep it open.
Prostaglandin.
Oh, yeah.
PGE.
Right. This one's due often to congenital rubella and prematurity, and this is really fucking obvious when you hear it because the sound just doesn't stop. So, yeah. Any questions on any of these?
No.
Okay. Alright, so calcium channel blockers. So we've got two different classes of calcium channel blockers. We got dihydropyridines and we've got the dihydropyridines. The dihydropyridines, you can remember them because they all end in dipene. So the difference between these two is that the non-dihydros, verapamil, diltiazem, they work more on the calcium channels of the heart, whereas the dipenes act more on vascular smooth muscle. Now, and again, I am disclosing this is first aid material, so just saying. What they mention in first aid is that this is kind of like a sliding scale as to how much these guys work on cardiac versus the smooth muscle, vascular smooth muscle. Meaning that even nifedipine can act on the heart, but not as much as verapamil. And same thing here, amlodipine can work on, they can all work on all of them. It's just like a sliding scale. So verapamil and diltiazem more so on the heart, and these guys more so in the vascular smooth muscle. So these guys work here at the L-type calcium channels in the vascular smooth muscle, and because of this, they are able to decrease the amount of intramyocyte calcium, and so that's going to be directly proportional to the amount of contractility that a myocyte has. So they're decreasing contractility. And if we're looking at it from the pacemaker cells of the heart, here's where the calcium channels act. So they can prolong the phase zero. That's not very accurate, but they can prolong the phase zero component of the pacemaker pulse. So we're going to decrease the amount of depolarization, decrease the conduction of depolarization. So this is going to be useful in situations where we have excessive depolarization, such as angina, AFib, flutter, Raynaud phenomena. Because again, if you're talking about angina and Raynaud phenomena, they actually have very similar pathophysiology, where it is vasospasms. So if we can, again, if we can prolong this threshold and kind of calm it down, we'll decrease the amount of depolarizations, and we can decrease, essentially the seizure that the smooth muscle vessels are having, whether it's in the heart or whether it's in the peripheral vessels. And this is just to show you guys that the verapamil and diltiazem, they work more on the 80 nodal conduction areas. So this is how they'll be able to slow down the AFib, just to, again, decrease the amount of depolarizations that'll happen, so that they don't have this, pancardio spasms like in a flutter. Okay. Specifically, nimodipine is the drug of choice when you have subarachnoid hemorrhages, and this is so that we're able to decrease the amount of blood that is going to decrease the amount of vasospasm that occurs, because when you have something like a subarachnoid hemorrhage, then as you can see here, we've got blood that's just kind of pouring out all over the brain, and blood is an irritant to vessels. So if you have a subarachnoid hemorrhage and blood starts pouring out, you want to prevent all the other vessels from spazzing out. So that's what nimodipine is going to do. It's going to calm down the other smooth muscles in the other vessels too. And then we've got some adverse drug effects here. And so obviously, if we're going to be trying to calm the heart down, then we can overshoot it, and we can cause things like an AV block and cardiac depression, which obviously isn't a good thing, but still can happen. And then same deal, if we're relaxing all the vessels in the peripheral body, then we can get things like flushing, because blood will be pooling into the most superficial areas. And we can get edema because there could be a total relaxation of the capillaries, and then they could start getting some leaking. Okay. Okay. So the reason that we can get hyperprolactinemia is because the arcuate nucleus in the hypothalamus, which releases dopamine, which is packaged in the vesicles, that release of dopamine is dependent on a calcium influx. And so if you inhibit that calcium influx to allow endocytosis, then you're going to increase the amount of prolactin that is being... Oh, I'm sorry. So you're going to decrease the amount of dopamine, which is going to increase the amount of prolactin. That's how that works. Yeah. So, kind of random there. And then we can get gingival hyperplasia more from the dipines than the non-dihydropyridines, but either of them can actually cause this. It's just more so in the dipines. Okay, now we got some questions here. Among the calcium channel blockers, which are most like nitrates in treating an angina, and which acts more like a beta blocker? So nitrate is more for inflammation, and beta blocker will be more for coronary arteries. So which ones work more?
Angina, could it be the dipines?
Yeah, this one would be the dipines, and so this one would be more like
Coxsackie, or the non-hydro.
yeah. So nifedipine would be the dipine, and verapamil would be more cardio-specific. All right, we got a 57-year-old man with a medical history significant for angina and hypotension. Presents because of worsening angina. He treats each episode of sublingual nitroglycerin, but has noticed that over the past year, the frequency of episodes has increased from once a week to daily. Patient is currently on the lisinopril. Note in the chart indicates that the patient is allergic to metoprolol, so calcium channel blocker is added to the patient's regimen. This medication has a clinical effect most similar to that of metoprolol. Which of the following calcium channel blockers is most indicated?
Verapamil?
Verapamil. We just said it's most like a beta blocker, and this guy's allergic to beta blockers, so we're going to give him the next best thing. A 1-week-old boy from a non-complicated vaginal delivery at 40 weeks gestation prevents for his first checkup. His weight, length, and head circumference are at the 50%. Physical exam shows a grade 2 of 6. Hollow systolic murmur best heard at the left mid to lower sternal border. Birth records show that no murmur was heard by 2 different healthcare providers in the newborn nursery. Which of the following is the most likely diagnosis? So it's hollow systolic. Yeah.
VSD.
The reason they give this, no murmur was heard, so this kid's 1 week old, and a VSD can take 5 days to a few weeks to actually present itself. So when the nurses or the pediatrician are doing the initial neonatal exam, they might not hear it for a few days. So that's why. 25-year-old woman with no significant medical history complains of palpitations and chest pain on exertion. PE is notable for mild fever and a new systolic murmur. Cardiac enzymes are elevated. The cardiac biopsy were performed at this time, which showed diffuse myocardial degeneration and necrosis with an inflammatory infiltrate. Pathogen most likely responsible demonstrates
So it's Coxsackie B.
Mm-hmm.
And so it's non-enveloped and single-stranded.
All the ones that we went over today were all positive. We only went over the positives today. So yes, it's non-enveloped, positive, single-stranded. And that's it. Because actually, if we just go back just to show you, the first 4 have no envelope, and then the bottom 4 do. So, if you remember them in a particular order, then that's always the best way to remember that. But they're all positive. So